All right, welcome, folks. We're going to let people trickle in here. My name is Stephen Beeson, founder of Practicing Excellence, and welcome to this clinical life. We have a massive registration on really one of the most important topics and challenges facing healthcare right now, which is why in the heck and what do we do that our industry, this healing industry, this service industry about making a difference in the lives of those in our community is subject to 5x higher incidence of violence than any other industry. And both Mel and Britt, who are going to be hosting this podcast, have compelling stories to tell themselves, as well as compelling actions that we can take to help make it better individually, as teams, and as organizations. As some of you know, this clinical life is about tackling in a raw, authentic, unfiltered, unrehearsed way the greatest challenges in healthcare with industry thought leaders who are in the trenches. So with that, I'm going to pass to my colleague, Britt DiNatale, who is one of our nursing leaders here at Practicing Excellence and brings tremendous expertise, not only in clinical nursing leadership, but also specifically in workplace violence reduction. And Mel Cortez, who is really a national thought leader and has really dedicated her life to how do we make nursing care better and safer and more restorative for those that are participating in this. And so I'm honored to listen and learn from two great colleagues. So Britt, I will pass to you, and Mel, thank you for joining us.
Happy to be here.
Thanks. Well, welcome everybody to the latest episode of This Clinical Life, where Dr. Stephen Beeson has kindly shared his hosting seat and let me take over the mic. As he said, we're here today with Mel Cortez, and I am excited about the opportunity to have this important conversation. For those of you that don't know me, I'm a client success advisor with Practicing Excellence and the Nursing Experience Project, and I'm also a nurse by training. I was an ED nurse for about a decade, and I am a proud second-degree nurse. So I made a conscious choice a little later in life to go back to school and join the incredible nursing profession. Here at Practicing Excellence, most of you know our mission is to inspire and empower every healthcare team member to thrive. And we carry out this mission through a coaching and development solution, microlearning platform that supports all healthcare team members to be their best. The work environment is a major factor in this equation. And today we're going to talk about one of the big barriers in the healthcare work environment for everyone involved, but particularly nurses, and that's workplace violence. I'd like to state up front that this is not a problem that is exclusive to nurses in any way. However, as the healthcare team member who typically clocks the most patient-facing time and the largest segment of the healthcare workforce, nurses tend to face the highest proportion of violence. You might be familiar with some of the harrowing statistics, but just to set the stage on what we're up against, in 2019, the American Nurses Association reported that 1 in 4 nurses has been physically assaulted at work, 1 in 4. And in 2022, Press Ganey published findings that stated that 2 nurses were assaulted every hour in the second quarter of 2022. This was based on a reported 5,217 assaults that quarter. Now, for a little context, an assault in that Press Ganey report was defined as any encounter involving forcible, unwanted physical or sexual contact, regardless of who carries out the assault and regardless of whether there is intent to harm. But it didn't count accidental contacts. Also, just for reference, in those findings, patients carried out the highest number of assaults. So these numbers might sound outlandish at first, but if you work in the healthcare environment, it is entirely possible that you are not surprised. But that begs the question, what do we do? And where do we begin? And to help us break this down and start thinking through some actionable steps, I am happy to introduce our guest today, Mel Cortez. Mel is also a nurse who works passionately in this space of workplace violence prevention, training, and advocacy. So welcome, Mel.
Hey, Hey, thank you so much. I'm so happy to be here. First of all, thank you to Practicing Excellence for everything that you guys are doing. This is just such an incredible platform. And, the way that you built it out with the healthcare worker as the centric focus is something that we need. And that's what's going to save our systems. I always say that the most important thing that we can do is be the scaffolding for these systems as they work to create change. Healthcare systems are like cruise ships, right? They take a long time to turn to do anything. And there's a lot going on from the, luau deck all the way, down to the engine room. So unfortunately, sometimes people from the luau deck find themselves in the engine room. And that's where we're at with workplace violence. Okay. We've got a lot of, mismatched places and things that are happening. And, I think when patients are sick, they are in a fight or flight mode. And I always say to people, the one advantage that we have is that they're a human and they all have the same human behaviors. No one is going to grow wings and fly away. No one's going to become invisible and disappear. Now, their behaviors can be disorganized. Grandma might be in there at night, ripping her clothes off, ripping her IV out because she's confused, or maybe there's a clinical thing that we need to look at. But the behaviors are the same. Hopefully, Britt, you take your clothes off before you get in the shower every day, right? So it's something that you do. It's just disorganized behavior. So our job as nurses, and particularly nurses, I heard this quote once that a nurse has to do everything that everyone else can do, but no one can do the job of a nurse. Right. So we have to be respiratory sometimes. We have to be the aide sometimes. We have to be housekeeping, but housekeeping can't be a nurse. Right. So that's why they kind of make the ideal leader in this situation. So the most important portion is to educate them so that they can be an adequate leader, so that when the behaviors are disorganized, they have a plan. They have a plan to help that patient or that family member organize their behaviors and not fault them for being human. That's one of the major reasons why I hate the word de-escalation. And I'm sorry to all you people out there who teach de-escalation training. I think what you're doing is awesome and thank you for helping. But that really places blame either on the patient for escalating or the healthcare worker, because sometimes I used to be that nurse. I used to be that instigating nurse. I am from Baltimore City. So I spent 10 years as a bedside nurse. I'm still working that PRN kind of role because I believe that A, they need the help, and B, how can I say that I'm practicing what I'm preaching if I'm not still practicing? So I enjoy my shift every once in a while. And I saw a lot of violence. Baltimore, the trauma center that I worked in, we averaged 9 to 12 gunshot wounds a night in our trauma season. So violence was just part of the narrative there. And when I started to travel across the country, I realized that security was not the same everywhere. And so that's kind of where this idea was born. And I just started educating myself. How can I be a better resource to my patients? And then how can I be a better resource to my colleagues? And that's kind of how this whole thing got started. And, now I'm happy to be here and being able to have these discussions and being able to help from the very basis of the bedside all the way up to the C-suite. How do we manage these problems and make it tangible for everyone, even though they might not see the violence? And of note to your statistics, Britt, when we do our research, it looks like more like 98% of all healthcare workers have experienced violence, have been a target of violence. And physical violence and verbal violence, or the threat of violence, actually have the same psychological response in the brain, because your brain cannot distinguish between what's actually happening and what's proposed to happen. That's how PTSD works, right? We fixate on a thought, and even though it's not actually happening, our brain perceives that and we have that stress response. So there is something to be said for different types of violence being categorized together. And that's a conversation I think that organizations need to have about metrics and looking at numbers, because they're grossly underreported as well.
Yeah. Yeah, I mean, underreporting is an important acknowledgement and something that we can talk a little bit more about, because it's absolutely true. And I do think one of the things that's really challenging about this issue is that it is complex and multi-layered from the point of definition all the way through to solutions, right? And that's part of what makes it really challenging. I love that you started us off with a cruise ship metaphor. I think we should just stick with our cruise ship throughout the conversation.
Good. I think it'd be fun.
So let's start at the front of the cruise ship and let's just work our way. Okay.
I love it.
I don't know my nautical terminology though, so I'm going to get myself in trouble. But let's talk about current state just a little bit to kind of set the stage, like as is. And this is not to lay blame, right? But just to acknowledge where we are. For me, I was fresh off of orientation the first time a patient took a swing at me. I was trying to put an IV in a gentleman who was intoxicated. Thankfully, motor skills were not at their finest, and the risk of actual harm was low. But it really made an impression on me because it set the stage of, okay, this is what's going to happen. And part of what made an impression on me was that it was considered normal. And there was no real flinching of, oh, someone just took a swing at one of our nurses. And my reaction also as a young nurse at the time was to want to feel like I could handle it, right? Like that I was competent, I was cool, everything's fine. So talk to me about first of all, how important is it that we acknowledge the scope of this problem as a first step? And how do we get back to basics and establish the idea that violence in the workplace should never be accepted?
Right. So I think the key thing to understand about violence itself is that when you do not have a presence of connection and no authority figure, you're going to perpetrate violence. So unfortunately, the climate, if we talk about the cruise ship, we're not going to turn around a cruise ship. The helicopter's going to come and take that sick patient off the cruise ship. They're not turning around, right? So when we look at going forward, we have to stay there. We have to focus on where we're going. And I think that's where the idea of it's never been something that was frowned upon. It was just societal norms that said you don't hit the nurse. Now, but there was never an actual formal, that's not how we do things here. So this is forward progress that we're in. So, a lot of people are like, how do we get back to this place? Well, there was no place of that. It didn't exist. So now we're in this innovation space, right? So number one, it gives us a little bit of hope, right? It gives us some hope and it gives us some space to create. So I think that as we move forward, we're looking at certain things that what causes the violence itself, right? So we understand that we have these numbers. We're starting to understand that those numbers are grossly underreported. So what is causing it? And at our company, we always say the security is not the absence of threat, but the presence of connection. So we're not going to stop somebody. There's a great book that I read when I first started this journey. It's written by a Marine named Jeff Cooper. And all the security people and defense people out there will know exactly who I'm talking about. But Jeff Cooper says in his book that the criminal does not fear judge, jury, or the jail cell. So the people that are going to perpetrate violence, that are doing it maliciously, are going to do it. So that's where we turn from these zero tolerance ideas or this culture of safety. We have to be careful using that verbiage because we can't promise the staff, just like you, Britt, in your experience where you were, almost hit by a patient. We can't promise them that's not going to happen because we've got psych disorders, we've got people that are, metabolic imbalances, and then we have people that are under substance abuse issues. So it's going to happen. It's just how do we prepare for it? And how do we make sure that they understand that we don't agree with it? It's not something that's okay. And that's where we shift to that idea of a culture of safety, right? So culture is defined as identifying a group of social norms or what we believe to be correct or incorrect in that culture, right? And safety itself is basically the protection from threat. So to say that we can have a culture of safety is almost impossible within a healthcare organization when you're talking about violence. But in order to have a culture of security, which is again, not the absence of threat, but the presence of connection, is something that we can work towards. And I think that the first step, that whether you're a bedside nurse or you're a leader or you're a physician or you're in administration, or you're a tech company, because there's some awesome tech companies that are out there that are stepping up to help with these solutions. The first thing that we can do is first acknowledge it. acknowledge that it's happening. Joint Commission before, when you report a violent event, is a sentinel event. So who's reporting sentinel events? Nobody, because we don't want to have to do all the work that comes with a sentinel event. But if we can prepare, so, the universal precautions for violence are a new Joint Commission regulation that's coming out, an OSHA regulation, and they're part of the new legislation that's filtering around. And that's a whole different conversation, but it basically says that employees should be prepared for violence. They should assume it's going to happen and they should be prepared for it. So just like universal contact precautions, right? We want to make sure that we're not touching bloodborne pathogens, and we kind of have that same standard. We should have the same standard for violence. And the way that we do that is through education. And by educating people about what is violence, what does it look like before it happens?
Yeah.
And my security advisors, when I was learning about all this, said, Mel, you're missing all the opportunities and all the cues to stop it because that person showed you the signs that it was going to happen before.
Yeah. So tell me a little bit more about, so prevention is our gold standard, right? And so we'll get to the fact that is impossible ultimately, and that we still have to be prepared for violence to happen. But in that gold standard, there has been a lot of movement in the last few years in that policy regulatory space. How do we translate that into best practices around training and education?
Yeah, so the OSHA and Joint Commission regulation recommendations are very vague. And that was some of the trouble that they had when they went into the Senate, right? Is like, how do we do this? There's no research really out there. Dr. Gillespie has done a lot of research, but he's probably really the only one that's done comprehensive research in this space. So the first thing is, piloting programs, piloting opportunities. And then when you run your pilot, make sure you have metrics that you're measuring. And it's not just how many times they get hit or what's the violence, it's behavioral cues. So we look at behavioral anomalies, and by teaching the nurse what an anomaly is, figuring out how to identify that patient's baseline, and then determining where the distance of capable care is. So those core elements are at the bedside. And then as a systems level, you're really going to start by gauging where you're at. And that's accumulating the data. And unfortunately, nurses are very busy. Everyone's very busy in healthcare. And now we're going to give them another task. And that's one of the major barriers that I hear from organizations is like, now I have to give the nurse another task. They're going to have to report this. The reporting systems that we have are wonderful for all of the other things that we report. They have different companies out there that are, you log in and do your report in real time. That doesn't really match up to what we're doing. And so that's where tech has the opportunity to really come forward. And there's some things that people are developing in that space that are really interesting to look at, but it's really the encouragement of the reporting. And even if I tell nurse managers all the time, even if it's just a half sheet of paper that someone can grab that says the room number, the patient, maybe put a sticker label on it, what happened, and the behavioral anomalies that they were able to identify.
Yeah.
And then put that under the door, and then we work on the report later.
Yeah.
But at least we're getting the numbers, right? So then once we can get the numbers, then we can start to identify if there's certain triggers. Is it high census and low staffing? And it is from frustration, right? Because security is not the absence of threat, it's the presence of connection. So if we're not connecting, why is that? Is it because the nurse in particular doesn't have really great, customer service skills? And there is a way to be customer service oriented and also stay busy. But some patients and some visitors, no amount of customer service is going to fix the disorganized behavior that they're exemplifying, right? So that's where we need to teach, okay, is this a customer service issue? Is this a behavioral issue? Is this a cognitive issue? Like, what is the actual issue? And then what is the solution from there? And the best way to do that is to train nurses to identify those behaviors and then be able to give them a set of protocol, right? So this is where this important part comes in. Nurses are great at following orders. You give a nurse an order set, they're going to follow it to the T because that's what they're trained to do. A lot of them, though, are not as creative or not as comfortable with coming up with their own solutions because they're busy and they're at this high level cognitive thinking, and they've got 1,000 things going on in their brain. So they don't have the time to really slow down. So that's where we give them the outline. This is what you're going to do when the patient says, I'm going to hit you. I tell organizations all the time, if I walk in there and I can look at any person with a badge, whether they're housekeeping, dietary, lab, and I say, I'm a patient, I'm going to hit you right now. They should follow the exact same protocol no matter where we're at. And then you have a culture of safety.
Yeah. And so getting into that, I think to me would require a lot of practice, right? Like, so another story comes to mind for me is as I was a triage nurse, I got myself in a situation that I shouldn't have been in, right? I was in a triage room that I'd never really thought twice about, that was about 6 feet wide and had doors that opened inward. And we would close the doors to triage, right?
Situational awareness.
And I never thought through the fact that if someone who was not particularly in their right mind pulled a kitchen knife out of their bag, which is what happened, all of a sudden, now I'm in a moment where I'm trying to think through what to do. And that's not the time I want to be thinking through that.
Exactly.
Right? So what are the things that we need to be making sure are key components that we're incorporating so that doesn't happen?
So the first thing is self-awareness, because if you don't know how you respond to violence, say, my unfortunately, I was a victim of domestic violence as a young woman. And so my response to violence is a little bit different. As soon as somebody gave me a trigger, a sign that I was triggered. So I automatically was defensive and, I tried to out authority them, but I'm 4'11", Britt. Okay. There's some people that I took care of that were 6'8", 250, 300 pounds. I'm not going to intimidate him. And it doesn't matter how mouthy I get, right? We're just going to keep going round and round. So that wasn't a good tactic for me, being authoritative. Now, if I was a 6 foot man, that might have been a good tactic, right? Depending on the patient. So the first thing is really self-awareness, understanding how you receive violence and verbal abuse, because it's a lot of a verbal abuse that triggers it, right? We want to defend ourselves because why are you talking to me like that? I'm just trying to help you. But they don't want to hear that in that moment. That's not what they want to hear. And then the second part is situational awareness. Understanding where you are on the unit. As a traveler, I traveled to, over 20 facilities in my career. So everywhere looked different. Every situation was different. Parking was different. And so that's something that I learned over time, was to be aware of what was happening. But that's something that you have to practice. And it's something that has to be permissible within the organization. So I tell tech companies all the time, okay, you're coming in to install cameras, or you're coming in to install a weapons detection system. That's great. Train the security, but you need to talk about situational awareness. It gives the organization an opportunity to open the conversation. And a lot of these people that are working for these tech companies are very experienced in this realm. So they're capable of, when they're delivering the program, designing a program, or if you're going to pilot something that opens the conversation for teaching, and then practicing. Yeah. So when you do your annual skills lab, a lot of hospitals do an annual skills lab. I recommend that you simulate an opportunity for violence. So one of my favorite simulations is placing a Foley. When you do your Foley care, and even nursing students, this is a great thing to use. Your hands are what? Your hands are sterile. So they're occupied. So your first thought as a nurse, if someone were to come at you, is to keep your hands sterile, right?
Don't break my sterile field.
It's not to protect yourself. It's to protect your sterile field, right?
Yeah.
So what are the things that we can do to be aware of that? Now, maybe the patient might not be particularly violent, because if they're getting a Foley, they're probably pretty sick, right? But we might have someone in the room that's potentially violent, especially in labor and delivery and these domestic violence. The rates of domestic violence are really high during pregnancy. Do you know why that is, Britt?
I don't.
And this is something I actually looked up. I was like, why is this happening? So people that perpetrate domestic violence often see their significant other as property. So imagine if you made a child and that person was carrying your property that's actually half yours.
Interesting.
You're going to feel like you can even do more, because and usually they're in a financial situation where they're dependent upon the perpetrator.
Yeah.
So they feel like that's why it increases, right? So those are things, behavioral cues that it's going to happen. And I tell nurses all the time, it is your room. It's your patient's room. You dictate what happens in that room. And that's where the organization needs to defend the nurses and have policy and procedure. So if the nurse says, you know what, I have to place this fully, this particular gentleman is giving signs that he may be a perpetrator of domestic violence, I need him removed from the room so that I can provide care. The organization has to have, number one, the capability, so security and the other elements of that, and also the training to the nurse to identify those behavioral anomalies, and to also tactical empathy. She understands that the reason he's violent is because he believes that to be his property. Same as if it was my child, so we have to tactfully use our empathy to help him move towards a coordinated goal. You want this baby to be born, right? This is something I have to do to get the baby born. So I need you to step out so that I can do that safely, and I can focus and concentrate and have higher level of recall so that I don't mess this up, right? I want to keep my sterile feel good and not cause her any pain and, not have any complications. Yeah. So it's simple instances like that we can simulate. That's very easy to simulate. And then you train them if the violence does happen because maybe he didn't want to leave the room, right? And we have to do it emergently. Then understanding that it's permissible to protect yourself once you become a victim. And having the hospital back you up. And that's the portion where the nursing note and narrative and documentation needs to begin then. He showed signs then. I identified 3 behavioral anomalies. I documented that quickly, whether it's maybe not in the chart because it's really not the patient, right? It's not her exhibiting those, but we document on that little half sheet of paper or whatever. And now if he comes at me and I have to defend myself or get out of the way or the sterile field's compromised, I have documentation to go to a court. And now we have that whole thing where hospitals are worried about legislation and getting sued and things. Well, it was documented. And my nurses are well trained in behavioral anomalies to identify that this was a potential problem.
Yeah. So we talked about the training and some components of that are critically important. Let's talk a little bit more about the reporting piece briefly, because, we touched on that earlier, but we can't really understand this problem if we don't have the data, right? And so we know that there are barriers to reporting. If I know that I'm going to have to stay an hour after my shift in order to actually report on what happened, by the time my shift is over, I'm like, was it really that big deal? Or do I want to go eat? Because that's really what how do we really emphasize, one, how critically important it is that this is necessary for us to understand and tackle this problem? And how do we make it as simple as possible so that it is encouraged? Or are there other ways that we can message how important this is to really build momentum around the reporting piece and the gap?
I think the most important is the buy-in from the top. You have to have leaders that are like, okay, we want to curb this problem. And I tell nurses all the time, healthcare CEOs could go off and run a Fortune 500 company. They could be running their business from Fiji if they wanted, but they choose healthcare for a reason. And many times it's because they have a knack for it, but they also want to help people. A lot of times you listen to their stories and their mom was a nurse or someone they knew died of cancer or whatever drove them to be in that seat. So it's understanding that we're here for a reason and we have a mission. And part of that is to connect with our patient, right? So, and as far as incident reporting goes, it needs to be a system-wide process. And I tell nurses all the time, if you're just a nurse manager, then run a pilot on your unit. Call it a pilot, say, we're going to try this. The half sheet of paper is a great solution. Another solution is really looking at what you're actually reporting. Because a lot of times it's like, what did you say? What did the patient say? What happened afterward? Did you have to use restraints? As soon as you put that down, it sounds very punitive. I don't want to report this because then I'm going to get pulled in the office. Then they're going to ask me what happened. Then so it starts with training, self-awareness, situational awareness, and then tactical empathy, learning. So now you've got a nurse, if they're putting the report in, they've been well trained about what to report, what to look for, and they are serious about reporting this because they know they've had extensive complaint resolution. You should have a complaint resolution policy. So CMS requires to have grievance, right? Grievance policies, right? That's a CMS requirement. And if you read that requirement from CMS, it states if the clinician is unable to resolve a complaint. Well, who's teaching you how to resolve the complaint? And what's the complaint resolution policy? We're jumping from got a problem, relies on the nurse can't fix it. So now we've got a grievance. But the only thing that we're documenting are grievances. By the time we're submitting a grievance to upper management, we've had a lot of opportunities to intervene. So as far as creating an environment where reporting is okay, it's policy, training, and procedure.
Yeah.
So, and when we go out to train, we do not just give you a blanket training. It's like, okay, what are the things that you have? Where do you want to go? And then let's build it around your policy. Your training should reflect your policies.
Yeah.
And so that's the first step, is really policy, what you're comfortable with, then implementing the training for the nurses, then it's practice.
Mhm.
And incident reporting shouldn't be something that's punitive. And after they report an incident, it should be encouraged. Great job, Mel. It looks like PCU has had 20 violent patients in the last month, and out of 20 of them, 2 went to grievance. Last month, 20 went to grievance. So now we're looking at, we were able to de-escalate the unit. We were able to move the metrics down. So what is the reward for that?
Yeah.
I love to use NFTs. First of all, NFTs aren't really, my son, what is he playing on Fortnite? He spends $40 a month on weapons that aren't even real. I'm like, what is an NFT, right? But he uses it for something, okay? So I encourage organizations to use a process like that, a point system, something where they can trade it in for swag or, whatever, coffee at the coffee shop, but reward them for participating. And when they do a great job, make sure that it's the CEO or the CNO or whoever's sitting on that workplace violence board comes down and says, man, I really noticed what you're doing and you're doing a great job. Then in the inverse, if you're seeing something, the trends, it's maybe one particular nurse that's really having a hard time. And every time the violence occurs, it's as a result of that nurse. That's where we provide extra training. And we also provide extra emotional support afterward. So the other night at my PRN job, I was telling you I had a really great incident to talk about. And there was a patient down there. I heard the code green overhead. The nursing supervisor was like, texted me. She's like, hey, Mel, I'm far away. I'm in the ED. Can you get there? You're in the next unit. I said, sure. I walk over. The patient is yelling at the nurse. And she even said, I don't know what it is. Is it burnout or are you just a, what? And she was cursing at her. And I could see on the nurse's face, it was like 11:30 and the patient still had 9 o'clock meds due. So that tells me a couple things. Number one, that unit is very busy. The patient wasn't that sick. So she probably was kind of her last stop, and she had given her critical meds and it was just like a vitamin and some other things. But the patient wanted pain medicine. And she was talking very, very fast. And when I went in the room, I just stood there for a minute and watched. And everybody's responding, right? Security comes, the other people come. And there's some great parts of the behavioral response team, but if you get too many people for the wrong situation, it can escalate things. And that's what happened here. So the nurse was in there and I look at her and I can see she was trying to be so professional. If that would have been my patient for all shift and she was talking to me like that, I don't think I could have held it together as well as Linda did. She was like, ma'am, I'm just trying to help you. And I could see she was starting to cry. So I went in, I said, Linda, go get the medication that she needs. I'm going to stay here with your patient. And she goes, oh, great. Another one of these dumb whatever is going to come in here and you're not going to be any better. But what are you, 12? All those conversations. And I didn't acknowledge her. I said, ma'am, are you? And I looked at the computer to make sure there was the right patient, right? Because if I'm going to provide care and I haven't been taking your patient, can I edit? And what's your birthday? Is your date of birth, whatever it was? And she said, yes, yes. So now we've taken her from this manic fixating on whatever. We've given her something that she can answer me. So now, okay, we're moving forward. How can I help you? She's like, well, you can't do anything, blah, 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 blah. And she just kept talking about the other nurse. I did not engage. There are some times where you're like, okay, I'm listening to you, or it seems that you have this issue. I always teach, never say, I hear you say, or you seem frustrated. because now I've placed blame on myself if I hear the wrong thing, right? And if I assume something, I place blame on her and I'm assuming the wrong thing. So now we've escalated. But if you say it seems, and you literally restate what you said, what they said to you, and they're going to say, you're right. And Chris Voss is a really well-known hostage negotiator. And when I started working towards this initiative, I said, you know what? I wore trash bags in the pandemic. I need something better, right? Who is the best of the best that I can find to help support us? And I went out and found them, and I started researching, started listening, and it was from other industries. And I said, you know, if we've been doing the same thing in this industry and it's not working and the rates are increasing, then let me find some other people. And so Chris Voss was one of the people that I really enjoyed. He has this company called the Black Swan Group, where they teach negotiations for the boardroom to get sales. And I started thinking, that's basically what we're doing. We're trying to sell our services. We're trying, in this customer service approach, we're marketing our expertise. So how can we market ourselves as experts? Because we know that the lack of connection happens when nobody thinks that we're an expert anymore. The COVID-19 pandemic and some other situations that are out there politically have really allowed people, Dr. Google, to think that nurses are no longer experts. So when you don't have that presence, they're not going to listen to you. So how can you quickly identify yourself as an expert? And the way that I did that was start with the basics. I'm going to do my 5 rights of medication because I'm an expert and I'm a specialist and I was trained to do that. So I started there. And then as she started cursing and getting belligerent, you don't know what you're doing. I ignored it. Now it was easier for me because I hadn't been in that room all night, right? If I had been in there, it might not have been that easy, but it was easier for me to do that. And so I was able to switch out with that nurse. Now, she didn't get a new assignment because we just didn't have the staffing to do that, which would have been ideal. You switch out and assign a new nurse, but that patient had already fired all the nurses on the unit and I was on a different unit. So I couldn't take care of that patient, but for that moment I did. And then the next thing I did was take her vital signs. Easy nursing basic 101, but it established me as an expert. Also, if something were to happen to the patient, because now it's unsafe for us to provide care because she threatened us. She said, I'm going to hit you, I'm going to kick you, whatever. So when I took the vitals, I came from the side. I knew she wasn't going to hit me because I wasn't the one that she was kind of fixated on, right? So I took her vitals. Now I know I have a set of vitals in case we cannot provide care for her or go back in the room to do anything. We have a last set of vitals that determines her as stable. So I'm protecting myself, protecting the patient. And then I said, here's your pain medication. What's your pain? 10 out of 10, 12 out of 10, because you're not doing what you're supposed to be doing. I swear, this is the worst hospital, blah, blah, blah. Security arrives, and not to knock my security folks, because you know I love y'all. He comes in, she goes, oh, great, security's here. You're going to kick me out now? And he's like, what's it to you? I was like, oh my gosh. I was like, come on, John, you need some gasoline for this fire? Like, now we're burning up the front of the cruise ship, okay? The luau deck is on fire because John decided to bring cigarettes, right? So I'm like, okay, this is not helpful. And so the nursing supervisor, who I have a good relationship with in that hospital, she looks at me and she goes, John, thank you so much, but I think we've got it under control. Clearly, John had a rough night as the only security guard in a 300-bed hospital. I don't blame him. So a lot of times relying on security is not ideal. So we have to train our nurses. And actually, Stephen, I see that John did go through extensive training. John's exhausted because he'd been hit and kicked and punched all night in the ED already.
Yeah, we've got some chat going on for those that might just be listening.
So John was having a human response, an emotional response to what was happening to him. And I don't fault John at all. But John's the only security guard in that hospital at night. So he's doing the best that he can do. So, and John's wife has cancer. And so he stays employed as a security guard, even though he's retired. He's like in his 70s because he needs the health insurance to take care of his wife. Yeah. So we have to know a little bit about our people and understand. And I said, John, I've got it. Thank you so much. You know, and he went along his way to start his hours of reporting that he has to do before he can get home, right? So, but because I'm well trained, and I've trained the nursing supervisor in our interactions, we were able to handle it. Now she starts doing complaint resolution. I said, Terry, not the time, because the patient was clearly manic, speaking fast, wouldn't let me talk, so I just gave her goals to work towards, right? So I'm like, our goal is to get me out of this room, everybody out of this room, and us done with the task that needs to be done. So how can I do that stage? So first asking her name, date of birth, doing the vital signs. Then I was able to give her the medication that she had due. I said, ma'am, you have some other medications that are due. Would you like to take those? And she said, yes, I would. I need those. Okay. And I said, thank you. I'm happy that I'm here to help you be compliant in your care. Yeah. That's one of my favorite phrases that security can use. How can I help you to be compliant?
So there's a lot of pieces here in this story, right? And it puts together a picture of just how much happens in one patient interaction and all of the things that we have to really think through and be aware of.
And that patient's completely different. That patient didn't need someone to listen to them. And the way that you could tell was because of the way she was speaking about her needs. Her eyes were darting. Clearly, she's a little bit, has an addiction problem. So those are things that we could identify. And later on, I looked in her chart and sure enough, she was bipolar and she hadn't been on any for bipolar meds. So another patient, maybe an agitated visitor, just wants someone to listen. So it would have been fine if I said, how can I help you? And really compassionate, just sat down in a chair, maybe if they weren't showing signs of physical violence, and really gave them an opportunity to talk. That probably would have been all that they needed. But the training is what determines what the behavioral anomalies are. So once we identify the anomalies, what does the next steps look like?
Yeah. So let's just, as one final kind of question here, I love how you brought up the nursing expertise and how that plays a role in the interaction, both in your training, but also in your ability to interact with the patient in a way that requires on the spot assessment and critical thinking.
Yes.
If you take a step back just for a minute to kind of wrap this up or move to the other end of the cruise ship a little bit, when you think about workplace violence as this overwhelming problem, and you feel as like one tiny passenger on this ship, what would you say to someone who feels powerless to make a difference in this situation? What is the sphere of influence that we have as healthcare providers to counteract some of what's happening? Where would you start?
First of all, educate yourself. Educate yourself, find resources like Practicing Excellence that are giving the micro content, and then support each other. After that whole interaction, I went and found Linda. I said, Linda, first of all, you were so professional. I don't think I could have been able. Are you okay? And she started crying. She said, I'm just so frustrated. I'm so tired. And it's 1 a.m. and I'm so behind. And we all were like, it's okay, Linda. And in that situation, when you could not appease the patient, your priority is now the nurse, because that is retention. Mm-hmm. The patient was stable, vital signs were stable. She wasn't going to listen to anybody. She was going to do what she was going to do anyway. Yeah. Now my priority is my colleague. Whether you're a bedside nurse, nursing supervisor, CEO, your priority is now the care and compassion of the nurse so that they can return to work and continue to connect. Security is not the absence of threat, but the presence of connection. Yeah. And if I know that she has my back after I walk out of there, the nursing supervisor is not going to go, well, what happened? We need to start the report. Karen needs to go take a break, or Linda or whatever her name is needs to go take a break, and then we'll come back and later do the report.
So a lot to think about here. I think it's time to really, I love what you're bringing up in terms of the culture of security being not an absence of threat, but a presence of connection. And I think as we think about the development of teams and the development of ourselves as clinical professionals and the development of our work environment, that we do have some level of influence around each of these and have steps that we can take. I know we've talked about a lot of them today, and there are bits and pieces that people can pick up on, hopefully, and take with them and start where you start, right? Whether that's the training piece, whether that's researching and understanding the tactical empathy that you brought up whether it's looking at your reporting and whether data transparency is really being used to improve the system and report on to understand the problem and find solutions in the corners where you can, right? There's so much there that hopefully I think people will pick up on as opportunities for improvement and in what is a challenging problem.
And each place is different. You may have different issues. You may have a different demographic. You know, when I was in Baltimore, all of our patients, a lot of them were gang members, and they hadn't really experienced life outside the block. I had a patient that hadn't left her block since she was 94 years old. So they don't know anything different. So if they don't know that, you can't really fault them for being in their human experience because that's their experience. But how can we navigate that? How can we understand that and then help them organize their behaviors?
Mm-hmm. Yeah. Great words, great advice, great stories and input, Mel Cortez. Thank you for being here and for doing the work that you're doing. It's incredibly important and valuable for all of us who are in this healthcare profession and those who want to support the healthcare profession to understand some of these problems that we're up against and how we can work together to make it better for all of us, because ultimately our environment matters, our safety matters, and it's all actually tied to clinical outcomes in the end, right?
Yes, it is.
So I want to share with everybody that information will be sent out as follow-up in communications around the recording of the episode and some follow-up information on Mel Cortez. But I really hope that you do feel a little bit inspired and empowered to take even the smallest next step in protecting the safety of your nurses, of the healthcare workforce, and that we can together create change. So thank you, Mel, for being here and being a part of this conversation, and keep doing what you're doing.
Thank you. You guys are wonderful. And remember that the answer is always more love. That is the true answer, and finding people where they're at and being able to navigate that. So thank you so much. And if anybody needs to reach out for anything, you know, I'm available and they'll send my information.
Yeah. All you need is love. I love it. Great. Thanks, everybody.